and it's my pleasure to welcome you to a Miles and Elena Zaremski Forum, named after Miles Zaremski, a graduate of the law school, and his wife, which endows a series of lectures on important topics in the field of health law. Today, our speaker is Sharona Hoffman. She is the Edgar A. Hahn Professor of Law and also Professor of Bioethics and co-director of the Law Medicine Center here at Case Western Reserve University. The title of her talk is Artificial Intelligence and Discrimination in Healthcare. If you have questions, we will have time for them after she finishes her presentation. Please type your questions into the Q&A, which you can see at the bottom of your screen, or click on at the bottom of your screen. And if you are interested in getting continuing legal education credit for today's webinar, the information about getting that credit will be given at the end of the webinar. So without more, Professor Hoffman.
Thank you so much, Max. Well, it is a pleasure to be giving this talk. The talk is based on a paper that just came out in the Yale Journal of Health Policy, Law, and Ethics. It was co-authored by Andy Podgorski, who also happens to be my husband. And I'm very excited to be giving a talk on this topic. So let me share my screen. All right, so artificial intelligence has been generating a lot of excitement, and that includes in the field of healthcare, and for good reasons. So let's talk about the positives. Artificial intelligence can improve treatment outcomes. So it can help doctors identify patients who are at risk of complications and will require hospital readmission, so they can tailor their treatment accordingly and try to prevent these kinds of problems. There's a lot of work being done, especially here at Case Western, on using AI in order to analyze tumor images so that doctors can tell which tumors are going to be very aggressive and require a lot of treatment and which tumors are going to be less aggressive, and perhaps you can spare patients really uncomfortable and expensive treatments if you can tell that their tumors are not going to be as dangerous for them. Oftentimes, researchers have trouble recruiting enough participants for clinical research, and so AI can be used to scan through thousands of records and identify people who might be a good fit for a particular study so that doctors know who to contact. And there are lots of videos on the web with all kinds of information about AI. So I just thought I would show you a 2-minute video by a doctor who is very excited about AI. Let's see if I can make this work.
AI, artificial intelligence, has some dangerous connotations, right? So I like to reframe it not as AI, but IA, intelligence augmentation. And I think we're going to see IA infuse all elements of our life. It's going to infuse everything from a physician standpoint about how I do a smarter workup and diagnosis. When I figure out a condition you might have, I'll be able to do a much smarter, more cost-effective, and more timely therapy. Given how many mistakes we have, how many misdiagnoses we do, how big a problem medical mistakes are, I think AI or IA can play a really impactful role. It'll be something you have embedded in all your smart devices that will help track your health and give you empowerment as a consumer and a patient to take care of your own health and that of your family. And it's already starting to happen with Watson having gone to medical school. We can access the API for Watson with our mobile devices. They're partnering with the Apples of the world, Medtronics, and I think it really has the opportunity to shift healthcare from the practice of medicine to the real science of medicine. So robotic surgery, even remotely, isn't science fiction. Companies like Intuitive Surgical have had advanced surgical robots for over a decade. They require often the surgeon to be there in the booth doing the procedure. It's even been demonstrated that that can happen across the planet. The real opportunity as we kind of fuse AI, imaging, sensors, is in some cases for some of these robotics to become semi-autonomous, to de-skill advanced surgery so that in a remote village with the right robotics, maybe a local country doctor can facilitate and enable more of a complex surgery that can never happen based on where the patient may be, whether it's on space station or Mars or in remote India, for example. So robotics blended with AI, blended with analytics and smart imagination, I think can really transform healthcare.
So very exciting. You may not be surprised that AI has been used extensively in the context of COVID-19. So it's been used to predict patients' disease course. It's been used to try to determine which patients are going to need hospitalization and ICU care and ventilators and so on, so that doctors know what to expect and how to treat them. We've also had some trouble figuring out exactly what treatments are effective under what circumstances. And so AI can be used to scan patient records, review how they were treated and how well they did with those treatments in order to be able to determine what therapies are most effective under what circumstances. And in other countries, AI has also been used to try to enforce public health orders. So it's been used to scan crowds for people who have high temperatures who shouldn't be out there in public. But interestingly, I've read that if you wear eyeglasses, that can mess up this scanning because they use the eyeballs to scan for temperature. So these are some of the positives of AI, and there's a very long list. It's really wonderful technology, but we academics like to focus on the concerns because that's more fun to write about. So one concern is privacy. So when you create AI and then when you use it, you are looking at a whole lot of patient records. You're looking at them in order to get training data that will train the AI. And then you're looking at them in order to try to analyze records and make predictions about patients. So the question is, will privacy be maintained? Are the data stored securely? And who is going to see identifiable patient information? And will they possibly misuse it? A lot of information is de-identified if you're just doing research, but at some point you are pulling records that can be tied to individuals, and that raises privacy concerns. There are also interesting questions about the physician-patient relationship. So the more we use AI, the more some people are concerned that we are moving towards medicine by computer or medicine by formula, and that might diminish the role of the physician. So will eventually the physician simply input symptoms into the computer, and then the computer will spit out a diagnosis, will spit out a treatment plan, and the doctor will just implement it? What will the role of the physician be? Now, we are far from that. AI just isn't nearly good enough, but it is interesting to think about what the future might bring. On the other hand, there are questions about whether doctors will trust AI suggestions if those suggestions are not traditional. So if you use AI to assess patient tumors and the AI tells you, no, don't provide chemotherapy to this patient, even though ordinarily you would, are the doctors going to trust that kind of advice, or are they going to be too concerned about liability? So what role will liability concerns play in terms of trusting AI advice? So the main thing that I focused on in this paper is discrimination, and we're going to shift gears and talk about that for most of the remainder of the talk. So we know in other fields, AI has led to discrimination, and these stories have gotten a lot of media attention and raised serious concerns. So in the area of criminal justice, they now use algorithms, which is how AI works, to try to determine what punishments to give different defendants. And they use it in order to try to predict recidivism risk, which defendants are likely to reoffend and which defendants aren't as likely to reoffend and can be treated more leniently. And so you might not be surprised to learn that these algorithms have been found to mislabel African American defendants as likely to reoffend and to mislabel white defendants as not very likely to reoffend. And then when you study what the people actually did, you find that those predictions were not correct, that people reoffended at the same rate, or that the African Americans, in fact, reoffended less frequently than the white defendants. And so you may have heard about this problem. In hiring, we've had similar problems. So Amazon is famous for using an algorithm that routinely rejected women applicants. So the algorithm's job was to weed through resumes and try to determine which candidates should be interviewed. And it said no to women and yes to men. Why? Because the training data, the data that was used to train the algorithm to do its tasks, was largely male resumes. And so the algorithm learned that male resumes were good, which means women's resumes must not be good. And so it just weeded out resumes of people with female sounding names or any indication of activities related to women, such as women's clubs or Girl Scouts or whatever. Same kinds of issues in the housing area. So Facebook was found to have an algorithm that kept minorities from seeing housing ads in certain areas. So if the algorithm knew you were white, it would show you houses in certain neighborhoods. And if it knew that you were Black, it would show you houses in different neighborhoods. And so I was not surprised to learn that there were similar problems in the area of medicine. So let me tell you some stories. There was an algorithm that was used to determine which patients should be referred to high-risk management programs. These are programs that provide resources and support to chronically ill patients, and so they can be really, really helpful. And the algorithm disproportionately referred white people and not African Americans. Why? Because the algorithm incorrectly used past medical expenditures as a proxy for medical need. So if you were a patient who spent a lot of money on your medical care, the algorithm would conclude that you are sick and that you should have the benefit of this high-risk management program. If you didn't spend a lot of money on your medical care, the algorithm would conclude that you are not very sick and you don't need this supportive program. What's the problem with this? Well, unfortunately, African Americans often have healthcare barriers. And so they don't have the money to spend on a lot of fancy healthcare, or they don't have access. They live in areas without a lot of access to good care. And so they don't spend money, not because they don't need the care, but because they don't have access to it. And so this algorithm exacerbated the problem. Not only were they not getting the care they need, they now were not referred to these high-risk management programs, even though they were very ill. Over in Canada, we have Winterlight Labs, which developed a machine learning tool, ML, machine learning, that is a well-known type of AI. And its job was to identify people with Alzheimer's disease. And it did this by analyzing the speech of patients. They were asked to describe a photo or a picture, and then the algorithm analyzed their speech to determine if they have early Alzheimer's disease. But this algorithm worked well only for people who were native English speakers, because the training data that was used to develop the algorithm came from native English speakers. And so it misinterpreted accents or searching for words or some hesitations in speech, not as an indication that you were not a native English speaker, but rather as an indication that you had cognitive decline. So it misdiagnosed all these people who were fine. They just were not native English speakers. And of course, in Canada, you have a lot of native French speakers. So it worked well for one population, but not for another. There was an algorithm that was used to identify patients who were likely to miss appointments so that doctors could double book their appointments and not lose money when the patients were no-shows. But of course, this algorithm also disproportionately disadvantaged people who were minorities or poor, because these are the people who have trouble finding transportation or childcare or getting time off from work. And so they do tend to miss appointments more often. But when they finally came to the doctor, when they were able to get there, they didn't get the care they need because the doctor had double booked the appointment. And so the doctor rushed through the appointment, didn't pay enough attention to them. And so once again, even though they were quite ill, had high medical needs, they didn't get the care they needed because of this algorithm that double booked their appointments. Interestingly, there are also algorithms that explicitly adjust for race. So they add points or subtract points depending on what the algorithm thinks your race is. Why is this done? Well, the developers of the algorithms study a lot of data, and they conclude that people in different populations have different outcomes or different diagnoses, and so they build that into the algorithm. But as I'll explain in a little while, these are usually very big overgeneralizations that can really lead to adverse outcomes for certain people. The American Heart Association has a heart failure risk score that adds 3 points for non-Blacks. And that indicates that non-Blacks are more likely to die of heart failure. And the problem with that is that this diverts resources away from African American patients, because the white patients are seen as being at severe risk of dying from heart failure, the African Americans not so much, so they get less aggressive and comprehensive care. There's a kidney stone algorithm that adds 3 out of 13 points for being non-Black. So if a white person comes to the emergency room with certain kind of pain, the white person is perceived as being likely to have kidney stones and is sent for all kinds of testing and treatment. An African American will be perceived as being far less likely of having kidney stones and won't be sent for that kind of testing. They'll be told, well, it's probably indigestion or whatever. There's an algorithm that assesses the likelihood of having a natural birth if you previously had a cesarean delivery. And this algorithm assesses people who are Black or Latina as being less likely to have a successful natural birth. And so they're most often scheduled for another surgery, which is not really good for you. And so we see that all these algorithms can have adverse effects for minorities. So these all raise concerns about health disparities, right? Minorities may suffer worse outcomes because of these AI problems. On the flip side, we also said a lot of AI is really good. It's cutting edge technology that makes good predictions about patients, accurate predictions about patients if it's done carefully. And this too can lead to health disparities, because If you're at a wealthy hospital or in a wealthy area, chances are your doctors have access to this technology. But resource poor areas may not have access to AI. And so this can exacerbate disparities. If you're at the Cleveland Clinic, they have the latest and greatest. If you're in some poor rural area, you don't have this technology that can be quite helpful. And when it comes to these algorithms that adjust for race, I have concerns about stigmatization, because that kind of AI seems to emphasize that there are racial differences, that there are somehow profound biological differences between people who have different skin colors. And as I said, that is not correct. And yet it sort of ingrains the notion that there are these differences that can be stigmatizing, that can fuel the fires of bias and prejudice. So let's step back and talk about why this happens. What are the reasons for algorithmic bias? First of all, you can have deficiencies in the training data. If the training data are not sufficiently diverse, the algorithm is not going to work well for all populations. So we saw in the case of the machine learning in Canada that assessed speech patterns, it worked well for native English speakers, but because it wasn't trained on non-native English speakers, it couldn't tell who had cognitive decline and who didn't. And so that was a problem with the diversity of the training data. Same thing with the algorithm that Amazon used to select people who for interviews. The training data came from men's resumes, and so it couldn't properly assess women's resumes. There's also something called feedback loop bias. So sometimes the problem isn't that the training data are not diverse enough, do not come from enough populations, but rather that bias is embedded in the data themselves. So for example, doctors generally learn how to detect heart attacks and heart disease based on men's symptoms. And for some reason, men's symptoms and women's symptoms can be very different. Men's clutch their chest and fall to the floor. Women have much vaguer symptoms that are harder to detect. Well, if the training data includes this problem that doctors only know how to diagnose heart attacks based on men's symptoms and not women's symptoms, and that trains the algorithms, it's going to perpetuate the problem of underdiagnosis and therefore under treatment. So you have diverse data, but there are just some errors, some bias in the data. It includes mistakes that are made with respect to women, and that is going to get perpetuated. Sometimes you just have poor study design, which also is somewhat common. We saw that with the algorithm that referred patients for high-risk care management programs, right? It was poorly designed. It wrongly used past medical expenditures as a proxy for medical need. And that was just wrong because some people don't spend money on healthcare because they can't, not because they don't need it. And then let's talk about these race adjusting algorithms. There are a lot of problems with the concept of race itself. What does it really mean? Does it mean skin color? Does it mean ancestry? Ethnicity is another word that's pretty vague. What does it mean? Race itself is a social construct. And so in medicine, what is usually going on is something else. It's not that people with different skin colors have different outcomes. Often the issue is a genetic variation. And some genetic variations are much more common among some populations than others. Some genetic variations are more common among white people or among African Americans. But no genetic variation is exclusive to one race or is present in everyone who is a member of a particular race. So take sickle cell anemia. We do usually think of that as an African American disease because it is most common among African Americans. But obviously not all African Americans have sickle cell anemia. And there are also other populations in which it's common. So people with ancestry from Greece, Sicily, and the Arabian Peninsula also commonly have sickle cell anemia. So researchers and people designing AI should be focusing on the genetic variation, not on skin color. In other instances, what's going on is social determinants of health. That is stress, diet, health habits, access to care, all of these social determinants of health. And yes, there are communities where you have worse outcomes because of the social determinants of health. And some of those are African American, but some of those communities are white. And so again, you shouldn't be focusing on race. You should be focusing on the factors that you determine matter. Does stress matter? Does diet matter? Does opportunities for exercise matter? That's what you should be training the algorithm on. And we also in this country have an increasing number of people of mixed ancestry. I looked it up, it's 6.9% that are of mixed ancestry now. That's well over 1.5 million people. And so if you have an algorithm that says treat African Americans differently from white people, what do you do with people who are biracial, right? So that's another problem. All right, so I do remember that this is a law talk. And so let's switch over to talking about the legal implications of discrimination in AI. And I do think that there are some gaps in legal protections that in the era of AI we need to address. So one issue is that a lot of these algorithms are designed to make predictions about people's future health problems. They are designed to identify who is going to develop cognitive decline in the future, or heart disease, or diabetes, or other diseases. And it is important to understand that the anti-discrimination laws that we have now do not prohibit discrimination based on future health conditions. So if an employer finds out that some algorithm predicted that you will have cognitive decline in the future, that employer is free to decline to hire you. The anti-discrimination laws address current conditions and past conditions. So you can't discriminate against somebody because they are currently disabled or have been disabled in the past. But nothing prohibits employers, landlords, others from discriminating based on future health conditions, on predictions of what illnesses you would suffer in the future. There's one exception, and that is if the information is genetic information. We do have the Genetic Information Non-Discrimination Act, which prohibits discrimination based on genetic information. But if the information comes not from genetics, but rather from an assessment of your health record, your health habits, anything else, then employers can discriminate if their reason is purely that you will develop some disease in the future. And so I think we need to close that gap. I think the anti-discrimination laws need to be amended to protect individuals against discrimination based on predictions of future health problems. Another problem has to do with disparate impact. So hopefully, none of this kind of discrimination is intentional, right? When designers design algorithms to help doctors. They mean to do the right thing. They mean to have a good algorithm that makes accurate predictions for everyone. But because of mistakes or overgeneralizations, some of these algorithms end up working poorly for certain populations, but that's unintentional. Similarly, when doctors use these algorithms, they're not intending to hurt anyone. It just so happens that these algorithms lead to poor outcomes for certain people. So this is unintentional discrimination. It's using a tool that has a disparate impact for certain populations unintentionally. If you are the victim of intentional discrimination in healthcare, you can sue as a private party. But you cannot sue for unintentional discrimination as a private litigant. Disparate impact litigation is available for private parties in employment, in housing, but not in healthcare. And so I think that is another gap that we need to close, because we now have AI that is causing a lot of disparate impact, a lot of unintentional discrimination. So these are some of the gaps that I have focused on. How is AI regulated? Well, not that well at this point. So the FDA is grappling with how to approach regulation of AI. Right now, it regulates some types of AI, not others. It has a proposal out to broaden regulation for AI, but it hasn't implemented that, and it's not clear what their final comprehensive approach is going to be to AI. And so they need to keep working on that, and they do need to pay attention to quality control relating to these bias problems, trying to promote algorithmic fairness in their oversight. Congress has gotten somewhat interested in this area as well. So in 2019, Senator Cory Booker and others proposed the Algorithmic Accountability Act. This would have required companies to study the algorithms that they use, identify bias, and correct problems that they detect. This bill did not become law. Congress seems to be having a little bit of a problem doing the right thing these days. So this was another failed attempt, but hopefully it paved the path for future legislation that will be more successful. I think it would be really beneficial to have some oversight in the law and through FDA regulations. And I also think that it would be important to make this a priority for AI designers and users. So algorithmic fairness should be a key element in designing, validating, and implementing AI. It should be something that people really pay attention to. Now, the thought I want to leave you with is that it's very nice to say that we should have algorithmic fairness, but the concept of algorithmic fairness in itself is very complicated. You can't have comprehensive fairness. You can't make everything completely fair. You often have to make some choices. You have to prioritize what kind of fairness is most important to you, because you can have tension between group fairness and individual fairness, or fairness in process and fairness in outcome. So a good example is, let's say a bank is trying to decide which customers should be approved for loans. And so it establishes a rule that you will be preliminarily eligible for a loan if you earn $50,000 or more, because they want to make sure that you can actually pay back your loan. So they have a clear $50,000 cutoff. Well, that is fairness in process, right? It's facially neutral. It applies to everyone. It's a clear rule, but you might have discrimination in outcome. because minorities might disproportionately not earn $50,000. They may more often earn less, in which case they would be disproportionately rejected as applicants for loans. So the process is fair, it's clear, it applies to everyone, but the outcome is problematic. And the same applies when you consider group versus individual fairness. If you have a clear-cut $50,000 requirement, then all your individuals will be treated the same. They will be rejected if they earn under 50,000, and they'll be preliminarily approved if they earn 50,000 or more. But again, you might have group discrimination because minorities, people with lower income will not be approved for loans very often. And so if you are worried about group fairness, you might have to bend that rule on the $50,000 requirement, and then you have individuals that are not treated the same. Depends now on what socioeconomic group they fall into. So it's complicated. You have to make decisions, you have to prioritize. There are experts now that dedicate their careers to algorithmic fairness. And I think this is a field that is growing and becoming more and more interesting. So I think I will stop here and we will take questions, which hopefully we have.
Thank you very much, Professor Hoffman. We have some questions. The first question is, are certain types of institutions more likely to produce flawed algorithms? For example, insurance companies versus academic institutions. For example, an insurance company, an analogy would be to insurance companies that use flawed data for underwriting standards.
Right. I have not seen a study that has identified a particularly bad industry. I think we need to be aware that it happens everywhere. It happens in hiring, it happens in criminal justice, it happens in medicine. Of course, the better the developers are, the more sensitive they are to these issues, the less likely you are to have problems of bias. But the takeaway message is that it happens everywhere. And if you're not careful, it's more likely to happen. So yes, if you have insurers that are sloppy, then it's more likely that they will have problems with bias.
Okay, thank you. Another question is whether Section 1983 could be used as a vehicle to attack disparate income algorithms against, say, a public institution like the VA or a public hospital.
Yeah, Section 1983 is hard to prevail with. It's challenging, but certainly if you think that you were deprived of your civil rights because of a public entity using an algorithm that disadvantaged you, I think that's possible. I'm actually now wondering to what extent disparate impact is available in Section 1983 cases. And for that, we need one of our constitutional law experts, which I am not. So if disparate impact theory is available under Section 1983, that would be useful for discrimination by the government, but I can't 100% for sure say. Do you know, Professor Melman? No. Okay. I'm in good company.
I mean, I think so, my recollection, but I don't want to vouch for it. Okay, so we have another question, which is, given the predominance of Caucasians, particularly Caucasian males in the tech industry, how can you change the unintentional cultural bias, particularly if people aren't aware that they have such biases?
Right. So that's one of the reasons I got interested in writing about this. So it's important to educate people about this. I have been impressed as I've researched the topic. There is more and more literature developing about this. So there does seem to be emerging sensitivity to this problem. The stories certainly about the criminal justice system, hiring, housing. Those have all gotten some media attention, as have some of the algorithms in that have to do with medicine that I talked about. So it's important that the media continue to focus on this, and you can Google it, you'll see. And it's important that scholars continue to focus on this, because we do need to have some educational initiatives. And I was encouraged to learn that Congress actually had a proposed bill, so it does seem to have reached pretty high levels.
By the way, one of the participants in today's webinar is a colleague of Professor Hoffman's and mine, who is a constitutional law expert and who tells us that disparate impact as a route for addressing discrimination would only be available if it were provided for in a relevant federal statute.
So generally, Section 1983 does not include disparate impact. Okay.
So you talked about the Algorithmic Accountability Act as having been introduced some years ago. Is there any expectation that it's going to be reintroduced? Was it just a one-shot effort, or did they try to reintroduce it and fail more than once?
So it was reintroduced it was introduced initially in 2019, so that's not that long ago. There was a lot of pushback from industry. There were critiques of various provisions of it. So it was not widely embraced, but I think it will be reintroduced at some point now that we have a different administration and other people in Congress. I think there's enough interest in it. And again, it was introduced by Cory Booker, who's pretty ambitious. He was a presidential candidate. So I would assume we're going to see something like it again, though I'm pretty sure it won't be in the exact same form, because they do have some problems to correct.
A related question is a lot of the push for electronic medical records, including electronic systems that would use the AI that you're talking about, come from the Centers for Medicaid and Medicare Services in relation to payment for Medicare patients. Is there any efforts that we see in CMS to address this problem that you're aware of?
I have not read of any special project within CMS that has to do with algorithmic bias. And so I'm not sure it's a focus for them, but I do know that the FDA is paying attention, and as we discussed, Congress is paying some attention. So there are government entities that are aware of the problem and interested in addressing it.
And one further related question, is the industry itself taking any significant steps to address this problem?
Yes, I have seen a lot of discussion about how developers need to pay attention to this, about how algorithmic fairness needs to be a priority when AI is developed and tested and validated and then implemented. They certainly don't like the media exposure. They don't like stories such as the Amazon story or the housing story with Facebook. And so there is some awareness, but it is very difficult, as I said at the end, to actually achieve complete fairness. It's difficult to get data that are diverse enough, because often the data come from a particular entity is trying to develop AI, and so they use their own records. Cleveland Clinic or Yale has a big program, but if you use those kinds of records, they aren't going to be sufficiently diverse. So it's hard to find records that don't contain some kind of diversity problem or embedded discrimination.
Well, we have a question. I think it can be targeted at the failure to enact the Algorithmic Accountability Act, but also any other legislative attempts to address the problem. Do you think the problem is political differences, infighting, and so forth, rather than a lack of understanding on the part of legislators about the nature of the problem and the need to address it?
Well, I think a big problem with the Algorithmic Accountability Act is industry is not necessarily thrilled about more laws that they have to comply with, and for which they can be held liable if there are violations. And so you get a lot of lobbying from industry, and the tech industry is big, and we of course want to have technological advances, don't want them to be angry or feel stifled. And so you got a lot of pushback, people saying this won't work and that's not realistic, and our costs will go up because of litigation or compliance. And so that is part of the problem. And yes, that does translate into political infighting among advocates and opponents. And so you have to get industry buy-in, you have to make sure they're involved in the drafting process. And you do have to educate legislators to make sure they understand that this is a sufficiently serious problem that they should be willing to take action, even if it has a little bit of a political cost.
Another question is, do you know if there is any state initiatives, legislative initiatives or regulatory initiatives to respond to this problem? And if not, should there be?
Yes, I have seen a couple of initiatives at the state and local level where state or local committees have been formed, and I think a couple of broad laws have been passed that say that the government of that locality or that state will pay attention to issues of bias, that they are responsible for trying to make sure that the AI they use does not have serious bias problems, and that they will look for that when they assess AI outcomes. So it's not a lot, it's a couple. I think there's something in New York, possibly something in Washington state, if I remember correctly. So I've seen a couple, but it's not exactly sweeping the country, but it's not completely ignored.
So we have a response from one of our participants that CMS is aware of the bias in terms of cherry picking healthier patients that is used by Medicare Advantage plans, in other words, managed care plans under Part C of Medicare. Whether that,
I'd be curious, are they doing anything about it? If you get a response to that.
yeah, and if anyone who's present has any information about CMS and this, just put it into a Q&A and I can relay it to the group. Let's see. So we have some general questions about AI in medicine that aren't specific to discrimination. So let me just float some of those to you. One is, are you concerned that AI will get beyond, in medicine, let's say, will get beyond human control? In other words, that it will be self sort of perpetuating and generating? I mean, how autonomous can we expect AI in medicine to become, is one way of asking it.
Right. I mean, doctors are worried about liability, and so I think they're going to try to control that. But there are algorithms that are locked, that you train them once and they do the same thing again and again and again. And then there are algorithms that are more fluid, that learn as they go along. And therefore, the outcome you had last year for the same kind of data may be different from the outcome you get next year, because the algorithm has learned and has changed and has switched the way it does things. And so that might be perceived as scary, because you cannot completely predict what it's going to do as it learns and evolves. And there's another distinction between algorithms that are explainable and algorithms that are black box algorithms, where the developers themselves don't know exactly what the algorithms are doing and how they're operating. And so that that also might seem scary. So yes, there are things that human beings do not completely control, but the AI is designed to be that way. So I don't think AI is going to run off and chop people's arms off or do surgery by itself or anything like that. We saw in the video robotics, but it's controlled by human beings. And I think doctors and developers, we have a robust enough medical malpractice field that I don't think they will run amok. At least that it doesn't look like that right now.
So we had the comment about the Medicare Advantage plans use of a bias to cherry pick. I think the point was healthier enrollees. Is there any evidence that AI in medicine is being used in other ways to maximize profits for providers? And if so, is that another form of discrimination that needs to be addressed?
Well, I gave the example of the algorithm that was used to double book appointments so that doctors would never be at risk of having a patient not show up and having an empty slot in their day. And so, yes, there is some evidence that it will be used to increase profits. And certainly if it can save time, if it can do things that doctors would ordinarily have to do themselves, like study images and so on, that will save time and that will increase profits. And the goal is that at the same time it does good, that while it may save time and increase profits, it also provides more accurate assessments for patients, better treatment recommendations, and so on. So that is the trick. It's not necessarily bad to increase profits. It just can't be at the expense of patient care and patient outcomes.
So we have an observation that a number of organizations, including the Department of Defense and the intelligence community, have published policy frameworks for the use of AI in their domains. And so the question is the approach of policy frameworks or guidelines an appropriate way to respond to this issue as opposed to, compulsory laws?
Right. So in the article, I do address some guidelines. The FTC has some guidelines. Those are a good step. And it's just up to your preference. Do you prefer guidelines and leave compliance up to individual developers and users? Or do you prefer a law with the threat of consequences if there isn't compliance? And a lot of people would say the problem right now is serious enough that you need not only a carrot, but a stick. And certainly FDA oversight seems like a good idea, but the guidance are a good first step. It depends how general they are also. Guidance is not going to be looking at every algorithm step by step and approving it, but it's certainly better than not having guidance.
Well, we're just about at the end of our time, and we need some information for those who are going to seek a CLE credit. So I will turn that over to Professor Hoffman, and I would like to thank everyone for their participation and for their excellent questions.
Okay, so the much awaited CLE slide, now that you've survived the program. You will earn 1 CLE credit for this program, so please complete the evaluation link that's available in the chat box. Hopefully it was put there. It's also available in your registration confirmation email. The evaluation must be completed within 48 hours, and here is the activity code. It is 456284. 456284. Please allow 30 days for your CLE to appear. And if you have any questions about CLE, please contact Patty Harbold. She's great and she knows everything, and you should contact her just to say hi in any case. So thank you so much for being here. I hope you enjoyed the program. And if you look on the Law Medicine page for Case Western, there are many more programs to come, and we hope that you will participate in them.